AABIP video educational series. Once the entry site is confirmed and marked, we inject local anesthesia to the entry site. Confirmation of entry site is gained by aspirating fluid with a finder needle. Once anesthetized, we use electrocautery to provide a 1 to 1.5 centimeter incision, then enter the pleural cavity with a combination of electrocautery and mechanical dissection. Once the track into the pleural cavity has been established, we advance our trocar through. Using the pleuroscope, it is important to first establish your orientation and anatomy. Since most of these cases involve a pleural effusion, the most efficient technique is to use the fluid level to establish orientation. We orient the field of view to show the fluid inferiorly, therefore the ribcage should be oriented superiorly. To identify anatomy and potential pathology, the pleural fluid should be drained almost completely. When complete, you can identify apical, anterior, and posterior chest cavity, mediastinum, lung tissue, and diaphragm. Here we demonstrate pleural adhesions. Pleural adhesions refers to the formation of fibrotic bands that span the pleural space between the parietal and visceral pleura. We use a vat suction trocar to gently lyse these adhesions using a side-to-side motion. Here is a comparison of normal versus diffuse malignant lesions in the chest cavity. Notably, the lesions are noted both on parietal and visceral pleura. We use a 2.4 millimeter cryoprobe for most of our pleural biopsies. The freeze time is dictated by the frozen zone observed during activation. Pleural diseases tend to require larger biopsies, therefore we aim for a frozen zone that is larger than the catheter tip. The scope and cryoprobe are then removed en bloc and the specimen is collected. When performing forceps biopsies, identify the rib and interspace, and only biopsy over the rib as demonstrated here. Here, the rib is identified by pressing on it with forceps. Biopsies are taken by gently pulling the tissue and the forceps parallel with the rib.